So my talk will be about detection and management of hemolysis. So I will be talking about the frequency of hemolysis. I will share with you some data. I will talk about mechanisms of interference, mechanisms of the ways that hemolysis affects laboratory assays. I will talk about the effect it causes to our tests. I will also mention the ways of detection and their advantages and disadvantages, and I will share with you the results of the survey that we recently undertook to understand how laboratories deal with hemolysis in Europe. So just to define hemolysis, hemolysis is a process of membrane disruption of red blood cells, but not only red blood cells, also other blood cells, accompanied by a subsequent release of intracellular components into the serum or plasma. And we can talk about in vivo and in vitro hemolysis, and I will, in my talk, focus only on in vitro hemolysis. So what is the frequency of hemolysis? How big is really the problem? Well, hemolysis is the most common cause for sample rejection, and it has been estimated by this CAP survey back in 1995 that hemolysis accounts for 60% of sample rejection when we talk about chemistry samples, of course. And this has been reconfirmed by a number of studies, and this one is just one of them done in my lab by my group. And we have also determined that hemolysis accounts for 60% of all samples rejected in chemistry laboratory. We also know that hemolysis is not equally frequent in every clinical setting, so it's more frequent in some departments and less frequent in some other departments. So we know, for example, and you all know that very well, that the frequency of hemolysis is highest in emergency department, pediatric department, intensive care units, and less frequent in some others. We know that hemolysis is caused by a number of errors, mostly during the venous blood sampling. And we also know that the highest frequency of hemolysis occurs when the blood is drawn by either syringes or catheters. And so the highest frequency of hemolysis causes when the blood is actually drawn too vigorously through either a syringe or a catheter. And we know, and there has been a study done by Yannick Adamuro and his colleagues, and I had the pleasure to take part in this study, and this study has demonstrated that actually hemolysis is associated with the pressure of the blood collection tube. So the higher the pressure, the higher of the concentration of free hemoglobin. So what is the mechanism of interference of hemolysis? There are four distinct mechanisms through which hemolysis is causing interference in a number of assays. Spectrophotometric interference, then due to release of the intracellular components into the sample, then due to the sample dilution, and last but not the least, due to chemical interference. Spectrophotometric interference occurs due to the absorbance of the oxyhemoglobin in serum with characteristic peaks at those three distinct wavelengths. So all laboratory measurements that occur within this wavelength will be affected by hemolysis. Hemolysis also, as I said, occurs due to the release of the intracellular components into the sample, and the analytes that are affected most by this type of interference are those who are concentrated, who are present in a high concentration in the cell, as in comparison to the extracellular compartment. And the analytes which are most affected by this type of interference are lactide dehydrogenase, inorganic phosphate, potassium, and aspartate aminotransferase. Hemolysis can also cause interference due to sample dilution. And the analytes which are affected by this type of interference are those which are present in much higher concentrations in plasma than in blood cells. So, for example, albumin, bilirubin, glucose, and sodium and some others will be affected by this type of interference. It has to be pointed out that this type of interference will actually affect the concentration of analytes only at very high degree of hemolysis, so up to or over 3 or more grams per liter of free hemoglobin. And finally, chemical interference can be either direct or indirect. Direct mechanisms are through either competing or inhibiting substrate or other components of the chemical reaction within the assay. Indirect mechanisms are those which modify the structure of the reaction components, either through precipitation, complexing, and through proteolysis. And proteolysis occurs due to the catepsin E, which is the highly prevalent proteolytic enzyme in red blood cells. And this is the cause of the most of the types of interference in immunoassays. So what is the effect of hemolysis? Well, the effect of hemolysis on laboratory parameter is actually a net result of all 4 mechanisms, which we just discussed before, and all 4 of them interplay together and cause a bias on laboratory assays that we measure. The effect can be either linear, it can be either positive or negative and linear, or it can be non-linear, again, either in positive or negative direction. And it has to be pointed out that the direction and the type of interference and the degree of interference highly depends on the assay and on the instrument. And this has been nicely illustrated by a couple of studies, and I will share with you the results of the 2 studies most frequently cited. The first one is done by my dear Catalonian friends, and the second one by the Nordic colleagues. And I'll share with you some examples. For example, folate. So the concentration of folate depends in a linear fashion, and the concentration of folate, or not the concentration, I'm sorry, the interference or the bias is greater. The greater is the concentration of the hemoglobin in the sample. The same goes for LDH. So the greater the concentration of hemoglobin, the greater the bias, and for some other analytes, like, for example, potassium. On the other hand, we have, for example, triglyceride, which may be affected by some instruments, or hemolysis may cause positive interference on some instruments, like, for example, those here, and negative interference on some other, like, for example, the Beckman-Coulter and Beckman-AU. The same holds for glucose. So glucose, again, can be either not affected at all by some assays on some instruments. It can have a slight positive interference on some instruments and negative interference on, for example, Siemens Vista. So what I'm trying to show here is that it is really important to understand and know the effect that hemolysis is causing for every particular assay on every particular instrument, to be really sure that we know the performance of our assays. As I said, this relationship can be either linear or non-linear. So, for example, calcium can be affected in a negative fashion and in a linear negative fashion by on some assays and some instruments, and in a non-linear fashion on some other instruments. So really it is very important to know what type of interference is occurring in my particular assay and on my particular instrument. So to summarize what has been said until now, most routine chemistry analytes are affected by hemolysis. The effect differs in direction and magnitude of bias. And the relationship between the concentration of free hemoglobin and the analyte can be linear and non-linear. Most immunochemistries are also affected, and this is just one example for troponin. So troponin on ortho can be affected in a positive direction, and for Roche there is a negative interference for troponin. And again, it has been demonstrated for a number of analytes So again, hemolysis can affect immunoassays in either positive or negative way, and through different sorts of bias, as already discussed before. And just to give you one example for FT4 immunoassay, which can be affected again in a linear negative fashion and in non-linear fashion in all sorts of kinds of curves. How do we detect hemolysis? Well, we can detect hemolysis by either visual detection or by automated detection, and we as a working group strongly discourage the visual detection and strongly encourage the automated detection, which is luckily more and more prevalent in laboratories worldwide. Why do we discourage visual detection, and what is wrong with visual detection? Well, visual detection is actually highly unreliable and highly inconsistent. It has been demonstrated by a number of studies. I'll share with you this one that we did with my group in Zagreb, with which we have actually been able to demonstrate the low concordance between the visual inspection and the automated inspection by, at that time, we have been using the LIH Olympus reagent. So the numbers in the boxes are the right ones. They show the concordance between the visual and automated detection, and the numbers outside the boxes are the ones that we don't want to have. And by this, we were able to demonstrate the very high degree of discordance between the visual and automated detection. What we have also been able to demonstrate is a very high, very low reproducibility between different assessors. So if you give a set of samples to 5 different technicians and ask them to rate the degree of hemolysis, then you'll see that there is a very poor reproducibility between them in terms of how well they detect the degree of hemolysis. And this has been demonstrated by this study, not only for hemolysis, but also for lipemia and icterus as well, by the very poor kappa coefficients between different raters. So the conclusion from this study for us was that visual inspection of lipemic, icteric, and hemolyzed samples is highly unreliable and should be replaced by automated systems that report serum indices. Visual assessment is not only highly unreliable, but also affects patient safety, and we have been able to demonstrate this with a study that we recently published. It was a retrospective study on a set of samples from the emergency laboratory. Data were collected back in 2015. At that time, the degree of hemolysis was detected by visual assessment, and then there was the individual decision on what to do with the sample, if the sample was hemolyzed or not. And then we did the reassessment of all those samples for a 1-week period, and what we were able to demonstrate is that if you detect hemolysis by visual detection, and then if you make an individual decision of what to do with the sample, then you will in 1 out of 3 times make a false decision. You will make an error. And this error will be either to suppress test, which shouldn't have been suppressed, or to release tests, which shouldn't have been released. Of course, not all analytes are equally affected by this error. So our question was, what are the analytes which are most critical if we do the visual assessment and individual decision? So we did the risk analysis to understand which are the analytes which are most critical to this process, and we were able to identify troponin, potassium, and bilirubin as the most critical analytes, which are also the most clinically important analytes in the routine laboratory. Okay, and finally, what is the situation in Europe, and how do we deal with hemolysis in Europe? So to understand this, we have done a large survey study, and out of this study, 2 papers came out. The first one was aimed to understand how laboratories in Europe monitor pre-analytical phase and how do they use those data. And the second study was aimed to understand how do laboratories detect and manage unsuitable samples. Both of those studies were recently accepted for publication in Biochemia Medica and will be available in 2 weeks from today online as free access papers. And both were authored by Yannick Adamuro as the first author who actually did the most of the work. We have been able to collect 1,400 responses from 37 European countries, and the survey is quite representative of Europe, I would say. We had a nice distribution of laboratories, primary care and hospital laboratories, and we were quite happy to see that most of the laboratories, so 84%, do monitor HL indices. However, it has to be pointed out that there is still a high proportion of laboratories, 14%, which still, unfortunately, do not monitor HL indices. When we ask laboratories how do they measure or how do they detect the degree of hemolysis, we were quite disappointed with the fact that almost 30% of the laboratories still use visual detection. I've just shared with you the data showing that visual detection is highly unreliable and dangerous for patients. 42% use automated Hill indices, and 1/3 of the laboratories are using the combination of both. So probably for one set of analytes they use automated, and then for the rest they just detect it visually. For those who perform visual check, we were hoping that those laboratories would at least have a color scale which could help them to compare the color of the sample with the color of the scale. And this is why we asked them, do you use a color scale to detect samples by visual detection? And unfortunately, the answer was no for 2/3 of the laboratories. So 2/3 of the laboratories are not using the color scale when they detect the degree of hemolysis. We in Europe have a very different understanding of what is hemolysis and how do we define hemolysis. So in Europe, hemolyzed sample can mean anything from 0.1 gram per liter until 1 gram per liter. So we have a pretty much very different understanding of, how do we even define what is a hemolyzed sample. Now, once we decide that the sample is hemolyzed, so once we have detected the hemolysis in the sample, then we have to make a decision whether we will accept the sample for testing for all analytes, just for some analytes. Will we reject the whole samples? Will we do some tests and then release the results with a comment or without a comment? And this was the question that we asked the laboratories. So what do you do when you have hemolyzed samples? What do you do with this kind of samples? And luckily, only a minor proportion of laboratories reject the whole sample. That was nice. The majority of samples actually reject only those tests which are affected, which was great, and they release appropriate comment. However, there is a proportion of laboratories which would release all results with just the general information of, about sample hemolysis. And then there is a minor proportion of laboratories, but still there are laboratories in Europe that would release all test results without even reporting that the sample is hemolyzed. So there is quite a lot of heterogeneity in the way we in Europe manage samples which are hemolyzed. So not only we detect hemolysis in different ways, not only we define what is hemolysis, not only we manage hemolysis in different ways, but we also use different cutoffs to make those decisions, whether we will release the test or accept the sample for testing or reject the sample for testing. So when we asked laboratories, which cutoffs do they use to manage hemolyzed samples, then half of the laboratories said, well, we use parameter-specific cutoffs provided by the manufacturer. Then there was a minor proportion of laboratories which are using in-house developed cutoffs for particular assays. Luckily, there was only a minor proportion, 1.6% of labs, who are using same cutoff for all analytes, which is obviously wrong. And then there's a large proportion of laboratories which use either visual check and then individual decision, or automated detection, but then again followed by visual check and individual decision. So again, a lot of heterogeneity and a lot of room, a great room for improvement here. When we ask those laboratories which use manufacturer declarations or manufacturer suggested cutoffs, did you verify those cutoffs in your laboratories before you implemented the assays? Then 60% of laboratories declared, no, we didn't. We believe manufacturers, so we take those declarations and we use them to make our decisions on whether we will accept the sample or reject the sample for analysis. And I truly believe this is very wrong, and the speaker after me will be talking about the reasons why this is a very wrong practice. So to summarize everything that I have been talking about, hemolysis is the most common pre-analytical error. It affects many analytes. It affects analytes in many different ways. Our practices in Europe, so the way we detect and manage hemolyzed samples, are very heterogeneous and are not, unfortunately, standardized. And this creates a risk for reporting wrong results. And of course, risk for diagnostic errors, meaning misdiagnosis, wrong diagnosis, or delayed diagnosis. And we are, by doing it this way, really compromising patient safety. So we have to admit that we have a problem. We cannot hide ourselves from the problem anymore. And I believe we have to do something about it. So the obvious solution is actually to standardize the way we detect and manage hemolyzed samples and base our decisions on the available evidence. And this issue will be addressed by the next speaker in our session. So that is all from me. Thank you.